GI physiology, pancreatic secretions, vitamin, mineral absorption, and Peyer's patches. So this is kind of going to be a Mod Podge of a bunch of different types of physiologies, just so that we can kind of fit it all in one video, because it's something that it's not too high yield. The only high yield portion would be the vitamin and mineral absorption, which we'll get to. But first, pancreatic secretion. So what I want you to know is that the pancreas secretes isotonic fluid, and in low flow states, essentially when you're not eating, you're going to have low flow states of pancreatic secretions, and it's going to be high in chloride. But during high flow states of pancreatic secretions, you're actually going to have high levels of bicarb, which makes sense. You're going to have high flow states of pancreatic secretions when you're eating, right? And so that means that there's going to be a lot of gastric acid in the duodenum. So bicarb is going to be high in high flow states in order to kind of neutralize that acidity coming from the stomach during, food states. But when you're not eating, the pancreatic secretions are going to be high in chloride. It doesn't need to be high in bicarb, okay? So there's a couple things that enzymes that the pancreas secretes. It secretes amylase, which is like a start for starch digestion for polysaccharides. Lipases, which is for fat digestion. Proteases is for protein digestion, and it includes trypsin, chymotrypsin, elastase, a bunch of different things, okay? All of which are secreted in their inactive form known as zymogens, okay? Then comes along trypsinogen. Trypsinogen is converted to its active enzyme trypsin by enterokinase, okay? Once again, not too high yield. And then trypsinogen or trypsin is going to pretty much activate all other proenzymes. So all of the proteases that we just discussed, it's going to help cleave them and activate them in their active form, okay? Now, that's pretty much it for pancreatic secretions. Next is going to be vitamin and mineral absorption. So this is the high yield portion. What happens first and foremost, and we're going to talk about B12 because B12 to me is the highest yield thing. You eat some type of food that contains B12, okay? And what's happening first is you have a breakdown of that food, mechanical breakdown, and you have the start of like chemical breakdown, digestive breakdown, starting in the mouth due to salivary amylase, okay? And so that frees up the B12 molecules already within the mouth, okay? Then B12 is going to travel down to the stomach and it's going to bind R protein, okay? It's going to bind R protein, which comes from the salivary glands, okay? So B12 is going to bind R protein in the salivary glands. Okay, and the reason behind it binding R protein is so that B12 can survive the high acid state in the stomach. All right. After it binds R protein, it's going to travel out of the stomach into the duodenum. Now, the issue is that B12 with the R protein bound to it cannot be absorbed. Okay, it cannot be absorbed with the R protein bound to it. So, in order for B12 to be absorbed, it has to get rid of the R protein. And so what happens is that we have our pancreatic proteases. They're going to come in, the pancreas is going to secrete these proteases and it's going to cleave B12 from R protein, okay? And that frees up a space for intrinsic factor to bind to B12 because B12 cannot be absorbed alone. It has to be bound to intrinsic factor in order for it to be absorbed, all right? And so intrinsic factor produced by parietal cells in the stomach is going to follow along, go to the duodenum. Right when B12 gets cleaved from R protein by the pancreatic proteases, intrinsic factor will finally be able to bind to B12. And once bound to B12, it can finally be absorbed, okay? And it's going to be mainly absorbed, vitamin B12 is mainly absorbed in the terminal ileum, okay? So that whole process is all very important, all right? So now let's think about what can cause some issues here. So the first issue that we're going to kind of face is pernicious anemia, right? So pernicious anemia is autoimmune destruction of parietal cells. So without parietal cells, you're going to have a decrease in intrinsic factor, IF. So decrease in IF production from superficial upper glandular layer of the gastric body and fundus, right? So you're going to see an overall decrease in B12 absorption. So the patient could present with macrocytic anemia because they don't have intrinsic factor, because intrinsic factor is needed for B12 to be absorbed. So in pernicious anemia, the patient gets anemia because of a decrease in B12 absorption, which can lead to an overall macrocytic anemia. All right, so that's the first thing. All right, well, let's say parietal cells are fine and we don't have pernicious anemia. Let's say that the patient underwent a total gastrectomy. All right, patient needed, weight loss surgery. They underwent a total gastrectomy, or for some reason or another, they underwent a total gastrectomy. Well, guess what? If you take out some of those gastric cells, you're going to have an overall decrease in intrinsic factor production because you're taking out a lot of the parietal cells. So you can present with B12 deficiency. So if a patient has a total gastrectomy, you have to supply them or supplement them with B12, okay? That's another pathology, okay, that we do as surgeons, as doctors. Okay, another one. Well, let's say we have a pancreatic abnormality and the pancreas is unable to produce its normal enzymes. Well, what happens? Exactly. Without that, you're not able to cleave B12 to R protein, right? So you're not able to cleave the R protein off B12. And if it's unable to be cleaved, then B12 can no longer bind to intrinsic factor and you cannot absorb it. So that is another pathology associated, okay? So keep this all in mind as discussing this, all right? Now, other vitamins and minerals that you need to know is that iron is absorbed as Fe2+, and it's going to be absorbed in the duodenum. Folate, okay, is going to be absorbed, which is vitamin B9, is going to be absorbed in the small bowel, okay? And then vitamin B12 is absorbed in the terminal ileum. All right, so you have to know the locations in which all those places are being absorbed. You will also have bile salts, bile acids, absorbed in the terminal ileum as well, okay? So let's say a patient had an ileectomy. That is another pathology that could lead to vitamin B12 deficiency, okay? So keep all that in mind. Now, some things they want you to know based off of just like vitamin and mineral absorption is a vegan diet. So if a patient has a vegan diet, you're going to expect a decrease in B12 because a lot of B12 comes from meats. You'll see an overall decrease in vitamin D and a decrease in calcium. And the decrease in vitamin D and the decrease in calcium can lead into osteoporosis. So vegan diet increases your risk for osteoporosis because of a decrease in vitamin D and a decrease in calcium. All right. And keep in mind, it can also decrease B12. But once again, it would have to be like a patient that has been vegan for many, many, many years because B12 stores are high in the body. All right. Lastly, back to pernicious anemia. All right. What they also want you to know about pernicious anemia is that the patient is going to experience increased levels of serum gastrin, increased gastric pH, and an overall decrease in parietal cell mass. This all makes logical sense. Okay, for pernicious anemia, remember, it's an autoimmune destruction of parietal cells. So what happens is that you're no longer able to produce as much acid. So if you can't produce that much acid, you're going to see an increase in serum gastrin because gastrin is not getting negatively feedback. It's saying, whoa, there's still not enough acid. Where is it? Let me produce more gastrin. You can see an increase in gastric pH because once again, you're not producing the acid, so the pH is going to rise and become alkalotic. And you're going to see an overall decrease in parietal cell mass because the parietal cells are being destroyed by autoimmune destruction, all right? And that's kind of the mechanism of action behind pernicious anemia, all right? So I hope this all makes logical sense. Kind of the vitamin and mineral absorption is very important. Remember, iron is absorbed in the duodenum, then folate, then vitamin B12 is absorbed in the terminal ileum along with bile salts, okay? So next is the Peyer's patches. Not much to know here, but what they want you to know is that these are kind of the immune cells. This is where the immune cells are located for the GI tract, okay? And they secrete IgA, right? IgA, because it's essentially like a mucus membrane, right? And IgA is located at those mucus membranes. Now, what they want you to know is that there could be hyperplasia of these Peyer's patches, right? Hyperplasia of these Peyer's patches in patients that become sick. Some type of infection could lead to hyperplasia of it, or you could have, some type of vaccination. Polio can cause it, polio virus. Also, the rotavirus vaccination is very, very important with Peyer's patches hypertrophy, okay? And overall, that can lead to a pathology known as intussusception because it starts as a lead point, okay? And we'll talk about intussusception later, but I just wanted to bring it up here for just physiology reasons. All right, so one more chapter for physiology, and then we can finally dive into the pathology of the GI system.